Hello, I'm Joyce O'Shaughnessy from Baylor University Medical Center, Texas Oncology and U.S. Oncology in Dallas, Texas. And it's my pleasure to be here with you today to talk about a very interesting topic that is a look back at why we do what we do, groundbreaking trials, but also a look to the future with new hypotheses. Let's start with some surgical concepts. And we'll start with Dr. Halsted, a very famous surgeon in the 1890s. And he believed that the breast cancer started in the breast, and then it metastasized to lymph nodes in the axilla. And then it stayed in the axilla for a while before it then, in a methodical way, then metastasized to the rest of the body. Shown here, we can see the liver and the bones. And so Dr. Halsted thought that in order to cure breast cancer, you had to remove not only the breast, but you had to remove all of the lymph nodes in the area that the cancer may have spread to, because you would save some women where the cancer was just in the lymph nodes but had not spread to the rest of the body. And so he did very radical surgery, and it was called the Halsted radical mastectomy, because he felt you could save lives by removing the breast and the surrounding lymph nodes. But then in the 1960s, a very visionary genius, Dr. Bernie Fisher, found out, he was also a surgeon, but he found out in his work in the laboratory that, in fact, at the same time that breast cancer cells were metastasizing to the lymph nodes, they were also metastasizing to the rest of the body. And therefore, what surgery you did on the breast and the lymph nodes was not going to matter if the cancer had already metastasized to the lymph nodes, because the chances were very high that the cancer had already metastasized to the body. And so what you did to the breast and the lymph nodes would not save a woman's life. And so Dr. Fisher conducted this trial called the B06 trial, a very famous trial where women, this is back in the 1970s and 80s, when women underwent either just a lumpectomy for their breast cancer, or they underwent a mastectomy, more surgery, or they underwent a lumpectomy as well as breast radiation therapy. And you can see in the overall survival curves, you can see that over 20 years, there was no difference in survival whatsoever. So what surgery you did to the breast did not make a difference in terms of a woman's chances of dying of breast cancer. This was absolutely revolutionary. And then it led to the idea, well, maybe we don't have to do as much surgery. And on the left, the original concept was that there would be perhaps several areas in the breast of breast cancer. Some of it might be microscopic. And that the various areas in the breast would drain to all different lymph nodes. And so it could drain to the blue dots that you see, or the light green dots, are the lymph nodes. And the breast cancer cells could drain to any of the surrounding lymph nodes. And so that's why so many lymph nodes were removed from the axilla, because the breast cancer could drain willy-nilly to any of them. But then it turns out that the concept of the sentinel lymph node hypothesis was born. And that's our current concept now, where you see multiple areas of breast cancer in the breast, but they're all draining to one or two lymph nodes in the axilla, the sentinel lymph node. And now we have techniques where we can inject blue dye or radioactive substance into the breast cancers and see where they drain, which of the lymph nodes the breast cancer cells drain to, and just remove those lymph nodes and spare the woman a great deal of axillary surgery, and therefore spare her lymphedema. So over time, what's happened is we've gone from very radical surgery, trying to save lives, to the realization that surgery alone does not save lives, and that you need to actually do less surgery in order to have less disfiguration and less chance of lymphedema. Conversely, we have found out over the years that radiation therapy to the lymph node areas around the breast if a woman already has lymph nodes positive in her axilla, if you then do radiation therapy to the other lymph node areas along the side of the breastbone, above and below the collarbone, that you can actually improve survival, decrease a woman's chances of dying of breast cancer. Shown here is an example, and you can see the squares and the rectangles there. That's the radiation fields. This woman has had a mastectomy. You can see the incision there. And there was a 5.4% improvement in overall survival at 15 years in women who had lymph nodes positive in the axilla, who had radiation therapy to the other lymph node beds. And that's because we cannot do surgery on the lymph nodes above and below the collarbone and down the breastbone. They're in difficult areas to reach. And so you can sterilize those lymph nodes that may harbor metastasis with radiation therapy. So we're doing less surgery over time, and we're doing more radiation now to women who have lymph nodes positive at the time they present with early stage breast cancer. So now let's turn to the approaches therapeutically that have evolved over the last several decades with regard to eradicating microscopic metastatic disease that has already left the breast cancer by the time it is discovered by the woman herself, her physician, or on mammogram. Micrometastasis that basically seed vital organs, and these are the cells that, if not eradicated or controlled by the woman's immune system, will eventually grow out and turn into a metastasis that is clinically evident and that the woman will eventually die from. And so one of the big breakthroughs in improving the cure rate in breast cancer is the agent tamoxifen, the anti-estrogen estrogen receptor inhibitor, tamoxifen. And what you see, for example, over on the left where it says breast cancer recurrence, we're looking at the percentage of women whose breast cancer is recurring over 15 years. And in the lighter blue color, that's the women who took 5 years of tamoxifen. And the darker blue color are the women who did not get tamoxifen. These are early clinical trials when they were showing the value of tamoxifen, testing the value of tamoxifen. And you can see that far fewer women had a recurrence of their breast cancer, or on the right, died of breast cancer with just 5 years of tamoxifen therapy. So that was the good news. But you see, the bad news is here that in spite of the 5 years of tamoxifen, those curves just keep going up. Women with estrogen receptor positive breast cancer are at risk for recurrence every single year, going up. Out here, going out to 15 years, we know it goes up even higher, going out to 20 plus years. So 5 years of tamoxifen was a definite improvement, a breakthrough, but it wasn't adequate. As a result of this, clinical trials have now shown that women, for example, who have lymph nodes positive at presentation, or women with larger breast cancers, they benefit from 10 years of anti-estrogen therapy instead of just 5 years. And you can see why that's the case. 5 years is not adequate. The risk of recurrence continues to go up over time, and it turns out, thankfully, that we can reduce this risk further with 10 years of anti-estrogen therapy. Another breakthrough is shown by this trial here, the Big 198 trial, where head-to-head comparison in women with estrogen receptor positive breast cancer, they were randomized to 5 years of tamoxifen or to 5 years of the aromatase inhibitor letrozole. There are 3 aromatase inhibitors. Here's just one of the 3 of them in clinical trials. And you can see the letrozole is in the blue. There are fewer recurrences, not dramatic, but fewer recurrences with letrozole compared to the 5 years of tamoxifen. And a very big breakthrough trial called the MA17 trial showed that taking 5 years of tamoxifen followed by 5 years of letrozole very substantially decreased the risk of recurrence in patients compared to just taking 5 years of tamoxifen. That was one of the biggest, most important trials we have ever had in breast cancer. So it established longer duration therapy as important for women at high risk of recurrence, and also established the importance of the aromatase inhibitors that can work even after a woman has had tamoxifen. So we've made progress, certainly, with regard to anti-estrogen therapy, but you see how inadequate it is. You can see that at 10 years here, we still have 30% of women whose breast cancers are recurring in spite of anti-estrogen therapy. And many of these women had already had chemotherapy as well. So another advance has come for premenopausal women shown here. Now, these are very young women. These are women under the age of 35 with estrogen receptor positive breast cancer. This is the SOFT trial. And we're looking again at the percentage of women whose breast cancer is recurring. So the higher curves there are the women who are having fewer recurrences. And the black curve are these very young women who were just treated with tamoxifen. 94% of them had already had chemotherapy. And then after chemotherapy, they either received tamoxifen in the black curves, but in the red and the blue curves, they also received a medication that was a medication given in the gluteal muscle intramuscularly of a medication that turns off ovarian function, suppresses the ovaries, turns off the major supply of estrogen in these young women. And you can see there was a substantial improvement in the women's chances of remaining without recurrence. This was a major, major breakthrough for young women. And now for premenopausal women who have chemotherapy and they remain premenopausal, they either still have their menstrual periods or that they still have estrogen, higher estrogen levels in their blood work. We now recommend the addition of, they're called LHRH agonists, to turn off and suppress ovarian function for 5 years. That was a very, very big advance for premenopausal women. Now, the next big advance that we're just really right on top of, and it's not FDA approved yet for high-risk women with early stage estrogen receptor positive breast cancer, are the so-called CDK4/6 inhibitors. These are palbociclib, ribociclib, and abemaciclib. And these are very important oral medications that block these proteins called CDK4/6. And you can see them there. And all of these arrows are pointing down to cyclin D and to CDK4/6. These are the key proteins inside estrogen receptor positive breast cancers that make the cancers grow. It drives the cell cycle. And all of these arrows are all the growth pathways that can impinge on CDK4/6 to drive cell division. So these are really breakthrough medications, these three oral agents, because it can stop the cell division of these breast cancer cells and lead to cell death. And one very important clinical trial that has reported now for early stage breast cancer is called the Monarch-E trial. And in this trial, women had chemotherapy. These are high-risk women with nodes positive, and they have faster growing breast cancer. So these are high-risk women. They received chemotherapy, they're receiving their anti-estrogen therapy, and then the women were randomized to receive the CDK4/6 inhibitor abemaciclib, otherwise known as Verzenio, versus placebo for 2 years, along with their continued anti-estrogen therapy. And you can see that the green curve on the top is the women who received the abemaciclib. There are far fewer recurrences in women who are receiving the abemaciclib compared to the gray curve in the women who received the placebo along with their standard anti-estrogen therapy, of course. And this is true as well for distant metastasis. The percentage of women who would develop metastasis is far fewer in the women taking the 2 years of the abemaciclib. So these data have been submitted to the FDA for their consideration for approval, and we're hopeful that we will have FDA approval before long of the abemaciclib to utilize in women with node positive breast cancer that's faster growing, grade 3 or a higher cell division rate. We will wait and see and keep our fingers crossed that this will come sooner than later and will be another advance in reducing the risk of recurrence of high risk estrogen receptor positive early breast cancer. Now let's turn to chemotherapy. Chemotherapy also improves the cure rate and reduces the risk of recurrence in early stage breast cancer patients, actually regardless of estrogen receptor status. This Milan trial here was the very first trial that showed an improvement, now going out 20 years, improvement in survival. 11% fewer women died of breast cancer because they received 1 year of CMF, cyclophosphamide, methotrexate, and 5-FU. This was a long duration of chemotherapy, but this was the proof of principle that chemotherapy could improve the cure rate in women with early breast cancer. And then that led in the year 2000, just a short 21 years ago, the NIH said that because chemotherapy improves survival, it should be recommended to the majority of women, regardless of whether they have lymph nodes involved, whether their breast cancer is estrogen receptor positive or not, whether they're premenopausal or postmenopausal. And the bottom line was, if the breast cancer was more than a centimeter in size, regardless of lymph nodes involved or not, chemotherapy should be given. So we were giving chemotherapy to absolutely everyone, and very, very definitely grossly overtreating women with chemotherapy until about 2006, when a conceptual breakthrough occurred in our understanding of the biology and the different subtypes of breast cancer, because the Milan trial included all women with all different kinds of breast cancer because we couldn't delineate the various subtypes. And then it became apparent to us around 2001, 2002, that there are 4 main subtypes of breast cancer. 65 to 75% are estrogen receptor positive, but the luminal A are the slow growing ones, and the luminal B are the faster growing ones. Ki67 is a protein we can measure in the pathology laboratory to look at the cell division rate, and a 15% or above is fast growing. And then we have the HER2 positive breast cancer, which I'll show you what that is in a second. That's 15 to 20% of breast cancers. And we have 15% triple negative breast cancers. And now we treat all of these differently. And I'll show you the clinical trials that have led to the understanding that we need to treat these breast cancers differently. A very, very big breakthrough is the 21 gene recurrence score. That's the oncotype recurrence score. And we see that these women who were node negative, estrogen receptor positive breast cancer, all of whom were receiving tamoxifen, they were randomized to receive chemotherapy or not. And we see in the upper right the low risk recurrence score. First of all, look at how few women recur. There's almost no recurrences. Those are like 95% of women are remaining recurrence free going out 12 years. And you see there's no improvement in their outcome with chemotherapy. Chemotherapy is the blue line. And we can see, however, down the bottom right, if they're high risk with the recurrence score, they do very poorly with tamoxifen alone. That's the dotted red line. The patients have a tremendous risk of recurrence, 40% in the first 5 years, but the chemotherapy dramatically improves their outcome. That's the top blue line, very few recurrences. This was a sea change for us. We realized we should not be giving chemotherapy to everyone. We should just be giving chemotherapy to women who have a high risk of recurrence by the recurrence score. And it turns out this means lower levels of the estrogen receptor and faster cell division. That's what makes a high recurrence score. But now we don't give chemotherapy to women who have a low recurrence score or a low mammaprint score. There's actually 2 of these tests now available to us to pick out the women with a low score or a high score, and we direct our chemotherapy to those with a high recurrence score. A big, big breakthrough. We give much, much less chemotherapy, thankfully. What about HER2 positive breast cancer? Well, you see the little pinchers over there on the left. That's a normal cell. All of our cells have a normal amount of HER2 because it helps keep our cells alive. And for reasons we don't understand, 15 to 20% of the time when breast cancer happens, one cell develops too many copies of the HER2 gene, and now you've got millions of copies of these HER2 little pinchers there that stick out of the cell and stick into the cell. And these proteins, the HER2 proteins, keep the cell alive in a big way. And chemotherapy is largely ineffective, and anti-estrogen therapy is largely ineffective because the HER2 is so strong at keeping these cells alive. And in 2005, we had this huge breakthrough in terms of improving the cure rate dramatically in women with HER2 positive breast cancer by adding the antibody, an antibody that coats the HER2 called trastuzumab or Herceptin, that coats HER2, takes out the HER2, and now the chemotherapy can kill the cell. And now we have two antibodies that are standard in the curative setting that block HER2, trastuzumab and pertuzumab, otherwise known as Herceptin and Perjeta. Big, huge improvement in the cure rate with the addition of the trastuzumab and pertuzumab to chemotherapy. And we give it now pre-operatively before surgery to improve the cure rate. And why do we give it pre-operatively? Well, it's shown in this slide here. Over on the left, the oval, maroon oval, is the breast cancer. And what we do now is we give chemotherapy first. You can see the IV bag there. Then we go to surgery. And about 60% of women who have HER2 positive breast cancer on the top have what's called a PCR, pathologically under the microscope, a complete response. No cancer left in the breast or the lymph nodes. But 40% of women have RD, residual disease. There is still cancer in the breast or the lymph nodes in spite of getting preoperative trastuzumab, pertuzumab, and chemotherapy. And you can see on the right, the green curve, the PCR curve. If women have a pathologic complete response, they have a very low chance of having a recurrence. Very few women have a decrease on that green curve, which represents very few recurrences. However, with residual disease, we can see a very high chance there of recurrence very early on. If you don't get rid of all the cancer in the breast and the lymph nodes, that means you likely have not gotten rid of the cancer that had already metastasized microscopically before the cancer was found. So the breast and the lymph nodes are an indicator of whether the job has been done by the standard anti-HER2 directed antibodies and the chemotherapy. And so now the big focus is, what can we do for the women who still have residual disease in spite of our best therapy given before surgery? How can we improve the outcome of women with residual disease? A very important way to focus on those who need more therapy and not give more therapy to women who already have a pathologic complete response. And in the box there, you see TDM1, that's known as Kadcyla. That's another breakthrough therapy, which it's the Herceptin attached to a different powerful chemotherapy agent that further increases the cure rate for women who still have residual disease. So after their surgery, they receive 10 months of the TDM1, the Kadcyla, every 3 weeks, and that further improves their cure rate. But the women who have a pathologic complete response, they don't need the TDM1 because they already have an excellent outcome. So there's been a huge amount of progress in HER2 positive disease, and there's still a great deal of excitement to further increase the cure rate for those women with residual disease. Several trials ongoing. And then the last frontier in breast cancer is our most challenging breast cancer, and that is triple negative breast cancer. Why is it challenging? Because TNBC, triple negative breast cancer, is a grab bag definition. And it turns out there are several different subtypes of triple negative breast cancer that we're still in the process of understanding. First, understanding, and then secondly, figuring out how to optimally treat. And on the left, we see that some of the TNBCs are slower growing, 20 to 30% of them, and they act more like luminal, which is estrogen receptor positive breast cancer, though they don't have the estrogen receptor. And some of them act a little bit more like HER2 positive breast cancer, though they don't have the HER2. And we're figuring out the biology. And on the right, 70 to 80% are basal-like. And this is the more classic triple negative breast cancer. And they tend to be faster growing, and they tend to have more immune cells infiltrating the cancer, trying to kill it off, but not successfully. And the basal-like breast cancers are more highly curable breast cancers. And we still need to develop, quite frankly, better therapies for those that are non-basal. But a big breakthrough has recently come for basal-like breast cancers that are more highly immunogenic. They have more infiltration of immune cells in them. And it turns out, shown here, depicted here, that if you give chemotherapy to triple negative breast cancer cells, you increase the chances that the immune cells can see now those breast cancer cells as foreign and can kill them. So chemotherapy, by a variety of mechanisms, increases the immune system's ability to kill the breast cancer, and also, thankfully, increases the chances that some of our immune therapies, such as pembrolizumab or Keytruda, recently approved by the FDA for women who are receiving preoperative chemotherapy for their triple negative. We're now adding the pembrolizumab Keytruda to the chemotherapy to increase the chances of activating the immune system against the breast cancer to kill it off more and increase the cure rate for women. And we are very, very happy with this clinical trial, the Keynote 522, a really huge recent breakthrough where women are receiving in the orange boxes, thus the standard chemotherapy. All the women are getting standard chemotherapy before surgery. And then half in the darker blue are getting the pembrolizumab antibody that activates the immune system. And in the lighter blue, half are getting placebo. And then they go to surgery. And then after surgery, they receive either 6 months more of the pembrolizumab Keytruda IV or placebo. And you can see down the bottom in the red box that 13.6% more women had a pathologic complete response at surgery having had the pembrolizumab. That means no cancer left in their breast or in their axillary lymph nodes because they got the pembrolizumab. So it improved the chances of being cancer-free at surgery. But much more importantly, the pembrolizumab, the immune therapy, improved the chances of women remaining without recurrence. The two lines on the top are the women when they went to surgery, whether they had chemotherapy alone or they had chemotherapy with the pembrolizumab, they had no cancer left. And you can see there was a 2% improvement in the chances of remaining cancer-free going out 3 years from 92% up to 94% with the addition of the pembrolizumab. So just a little bit of benefit there from the pembrolizumab if you were already going to do well anyway with the chemotherapy. But much more importantly, down the bottom, no, the patients who did not get a pathologic complete response, we can see in the brown line, the patients who just got chemotherapy, in the green line, the patients who got the pembrolizumab, and we can see that there was more than a 10% improvement in the chances of staying recurrence-free with the addition of the pembrolizumab. So this is a big increment, a 10% improvement, and we hope what's going to be the cure rate for women is a big advance. Unfortunately, you can still see what the bad news is here. 67% of women remaining recurrence-free is way better than 56%, but we still have a long way to go. We can zero in on these patients who have not had a pathologic complete response. And those are the women who need more help. They need the pembrolizumab, but they need more help than just the pembrolizumab. And fortunately, we have another breakthrough. This, however, is confined to the women who have inherited a BRCA1 or BRCA2 mutation and who have breast cancer because they inherited one of these genes from their mother or father. And these women in the orange line now, when they're given a year of an oral therapy called a PARP inhibitor, here it's called, it's olaparib here, approved by the FDA, otherwise known as Lynparza, when those women who don't have a pathologic complete response, so they get preoperative chemotherapy, now they'll get it with the pembrolizumab. If there's still residual disease, they should get a year of this olaparib, and it will further increase the chances of remaining recurrence-free. Even if women have surgery first and then get chemotherapy after surgery, they should still get a year of the olaparib after the chemotherapy because the year of this PARP inhibitor further increases the cure rate. So this is another advance for us very recently for patients with who have inherited a BRCA1 or BRCA2 mutation. And this SASIA trial is just an example for women like in the Keynote 522 trial who received, for example, the preoperative chemotherapy now very recently with the pembrolizumab added, who still have residual disease. They get randomized, those who have residual disease, to either a standard of care agent such as the oral chemo pill capecitabine, otherwise known as Xeloda, which is standard to use 6 months of the Xeloda after surgery for those who have residual disease with triple negative breast cancer, versus in the green structure there is an antibody. That's an antibody called sacituzumab, and the little red lollipops coming off of it, it's loaded up with chemotherapy. And so women, half of the women are getting the sacituzumab antibody therapy to deliver a very powerful chemotherapy agent right to the residual cancer cells in a woman's body, versus the capecitabine oral chemotherapy pill. So we're hopeful that bringing in the sacituzumab is going to further increase the cure rate now in patients with triple negative breast cancer. So that's an example of some ongoing clinical trials that we hope are going to make the next advances. And then I just wanted to finish in terms of chemotherapy and trying to pick out the women who still need help. We haven't cured them yet. There's a new way of doing clinical trial looking after a woman has finished her surgery, her radiation therapy, her chemotherapy. She's on anti-estrogen therapy because this example here is estrogen receptor positive breast cancer patients. What if we did serial blood work every 3 or 4 months, got blood work, looking in the circulation, looking in the blood for tumor mutations. That's called ctDNA, circulating tumor DNA mutations coming from microscopic cancer cells still in the woman's body. This may be a way for us to identify women who are not cured yet. And we can see the top line going across the top, women we do not find the circulating mutations, they do great. Here, there's no recurrences. But in the orange, women who we do find circulating tumor DNA mutations in the bloodstream, this is very poor. These women have a rapid and high risk of recurrence. So if we could find the women who are not cured yet using the ctDNA and then aim new therapies only at those women and not the women who we don't find the circulating mutations, hopefully we can make the next big leap in curing women before their cancer recurs. This is not something now for standard practice. This is a clinical trial design, finding these women who have the tumor mutations and then intervening with additional therapies before the cancer recurs. And then my very last slide, very, very important area of research. It's not standard yet, and that is to try to tackle the problem of obesity, because our obese patients at diagnosis have a worse outcome from breast cancer, or women who gain a great deal of weight, 10% or more of body weight after a diagnosis of breast cancer, have a worse outcome. And there's a variety of mechanisms, because obesity and weight gain increase insulin, which drives breast cancer. It increases estrogen, which can drive some breast cancers. It increases inflammation, which lowers the effectiveness of our immune system and does a host of other things. We must tackle the obesity problem. We have to help women prevent weight gain. We can help women with weight loss, exercise. So there are a number of clinical trials ongoing trying to help women with weight loss if they're obese, prevent weight gain, also increase exercise, to see whether these strategies, whether they will increase the cure rate in early breast cancer. We certainly hope that that is the case. And with that, I will thank you so much for your attention. It's been a pleasure putting this talk together to look back at the key trials that have brought us where we are today. We've made great progress. We are not there yet, but there is a great deal of excitement about the next set of hypotheses that are currently already in key clinical trials that will make the next leap of improvements in outcome for women with early breast cancer. Thank you so much for your attention.